Hi, thanks, Jeremy. Good afternoon, everyone. I hope you can see the slides and hear me clearly.
Yeah, looks good.
Okay, so like Jeremy said, I'm going to be talking about Bartonellosis today. And we'll just touch on a little bit of the interesting history and then go into some treatment modalities for some of the presentations. But just to introduce, Bartonella species actually belong to the alpha-2 subgroup of proteobacteria. And this is based on the 16S rRNA testing that closely relates to the genera of Brucella and Agrobacterium. But the three most important Bartonella species known to cause human disease are Bacilliformis, quintana, and henselae. So they don't take an equal piece of the pie like I've described here. But there have been other Bartonella species that have been reported to cause human disease, like Bartonella elizabethae, Vinsonii, Cladrigiae, among a few others. But today we'll discuss the three of most medical importance, including Bacilliformis, which has quite a distinct epidemiology. So we'll start with Bartonella quintana, which is a small fastidious gram-negative rod that was previously known as Rochlomea quintana, and very interestingly dates back to World War One, where quintana infection emerged as quite a big source of morbidity among soldiers, and at that time it was commonly referred to as trench fever. There were more than 1 million soldiers who had developed trench fever at the time, and there were military physicians who established this war office on trench fever investigation. And this was the group that first identified the causative organism for trench fever. And they determined that the human body louse was actually the vector for this infectious pathogen. And then a few years later, in the 40s, during World War II, there was again a significant epidemic, but much less extensive than in World War One. But it reared its head again in World War II. In terms of worldwide distribution, since about the 1990s, there have been sporadic cases that have been described in the US, some parts of Europe, Russia, Brazil, and East Africa. So Quintana infections occur, well, I said to occur in situations that foster very close human contact, particularly in environments with poor hygienic conditions where lice infestations can occur. And outbreaks have been reported in individuals experiencing homelessness, people living in refugee camps, people incarcerated, particularly those in crowded jails and prisons. HIV and alcohol use disorder is said to be an important risk factor, as well as injection drug use. But determining the overall prevalence of Quintana infection in at-risk populations is quite challenging, and this is in part because the infection may be asymptomatic and patients may not actually always seek health care. Serology antibody studies also so how this was actually proven was serology of antibody studies in impoverished or homeless populations, particularly in the US and France, had found quite a high number of positive Quintana serology in homeless populations compared to that of the healthy populations, and the healthy populations were surveyed by looking at the blood donor population in particular, and that's where this idea of it being a higher prevalence in homeless populations became apparent, or more apparent rather. In terms of the life cycle, so humans are actually the main host for Bartonella quintana, and the primary route of spread is via exposure to infected lice. And thus far, the available data suggests that body louse, particularly Pediculosis humilis corporis, is the predominant vector, although the head louse, this is Pediculosis humilis capitis, and sometimes Thyris pubis, which is the pubic louse, can also potentially transmit Quintana. And so what happens is lice become carriers of the organism, and this is by feeding on the infected human or another animal reservoir. And non-infected humans then acquire the organism from inoculation of the infected louse feces into abraded skin or conjunctiva. One infected lice can excrete millions of Bartonella quintana organisms in its feces per day. And the bite of the louse doesn't appear to transmit the infection to humans. So essentially, what happens is you get a bite, you scratch, and you cause these abrasions that essentially inoculate yourself with the feces, the infected feces that of the body lice. But aside from lice, there have been other potential vectors that have been proposed. For example, cats, although they're not natural hosts for quintana, but the organism has been isolated from cat fleas, the dental pulp of cats, and there have been some very few rare cases reporting a positive exposure to cats and cat scratches in patients with Bartonella quintana infection. So although humans are thought to be the main host of quintana, there are non-human primates, specifically macaques, that also serve as natural hosts for the organism. Um, so in terms of the disease presentation, so the incubation period ranges from about 5 to about 20 days, and this is really based on control studies of human volunteers who had voluntarily inoculated themselves with known infected louse species. But the incubation period is said to be about 5 to 20 days, and then what happens afterwards is you start to develop this febrile illness, which can have variable presentations ranging from a mild, limited influenza-like illness to a more chronic, debilitating kind of disease. But typical symptoms would include things like malaise, fever, headache, dizziness, bony pain, particularly pain in the shins. Patients may present with splenomegaly, nausea and vomiting, and also they may present with a macular truncal rash. So there are three major fever patterns that have been identified. So the first is a recurrent fever, and this is characterized by about 3 to 5 febrile episodes, and each episode is said to last about 4 to 5 days with asymptomatic intervals in between. And this was actually described as the classic trench fever, which was the most frequent form of the illness seen in the early half of the 20th century, including World War One. And here it was termed quantum fever or pentan fever because of these recurring 5-day attacks. Um, and then the second manifestation could be a single episode of fever. So this will be one episode lasting about 4 to 5 days. Or you may have a persistent fever that can last from anywhere from 2 to 6 weeks. So in terms of the spectrum of disease, so after the resolution of the febrile events, you may have a prolonged asymptomatic bacteremia, and this can persist for weeks, sometimes even to months. And patients may have either persistently positive blood cultures, or they may have an intermittent bacteremia. Um, so a high number of patients with Bartonella quintana bacteremia also have endocarditis. And the organism is also quite a significant cause of culture negative endocarditis, said to cause quite a high number, up to 15% of culture negative endocarditis in some case series, and maybe even higher in other sites like our own, which I'll show you a little bit about later. And then in individuals with advanced HIV, particularly those with CD4 counts under 100, Quintana infections have been shown to cause other disease entities like Bacillary angiomatosis and another entity called Peliosis hepatis. So we'll look at each of these in a little bit more detail. But in terms of chronic bacteremia, so you usually get resolution of the febrile events, like I said, and then you get this prolonged asymptomatic bacteremia that can persist for many weeks to months, or you may have just persistently positive blood cultures or an intermittent bacteremia as well. But the diagnosis of the bacteremia can be established on blood culture or on blood PCR results. But bacteremia is said to be probably quite significantly underdiagnosed, and this is because isolation of Bartonella on culture remains quite difficult. And PCR testing has quite a suboptimal sensitivity, has been quite useful in modern times now, but has quite a suboptimal sensitivity and is not routinely ordered, more so because of access issues. Essentially, when you are suspecting a bacteremia, you should be quite prudent in your physical examination and your basic laboratory workup, and you should be hunting for any other organ-specific Bartonella syndromes that we'll discuss now. But all individuals with the bacteremia should, at the very least, have an echocardiogram for an endocarditis workup. Which brings us to endocarditis. So the data thus far suggests that quite a high proportion, about 20 to 40% of patients with Bartonella quintana bacteremia actually have underlying endocarditis. The Bartonella is also quite a significant cause of culture negative endocarditis. Like I said, in some populations, causing up to 15% of culture negative endocarditis. In ours, we'll see a little bit more. Um, and it seems that henselae is usually more frequently associated with systemic emboli. But affected patients will present quite typically with typical features of endocarditis. But like I said, systemic emboli might be a little bit more common. So this is the Duke 2023, so the ISCVA-Duke criteria. And then I just wanted to highlight that how IFAs for detection of IgM, IgG, Bartonella antibodies for either Quintana or Hensley have been added to the major microbiological criteria after we are seeing more of these cases associated with infective endocarditis. So this was from a Cape Town study in 2021, actually, looking at blood culture negative endocarditis. And these investigators actually went down this algorithm of trying very hard to hunt for the causative pathogen for culture negative endocarditis. So they had done blood PCRs, tissue PCRs, autoimmune workup, and the results revealed that quite a high proportion of these culture negative endocarditis patients, when investigated with all the means that were available, were attributable to Bartonella species. And this was 46%, which is quite a high number. And then when this data was superimposed on the data from the culture positive cases, you can see Staph aureus was the commonest cause, but in second place was now Bartonella species, accounting for almost 20% of overall culture negative and culture positive cases. So this was quite eye-opening for us. Okay, so then moving on to the third entity that I was discussing was bacillary angiomatosis. So this is a syndrome in patients usually with advanced HIV who have CD4 counts under 100. And this could be caused either by Quintana or henselae. And affected patients will usually present with these vascular lesions that will frequently involve the skin, but can infect or affect rather other organs like bone and lymph nodes, etc. Quintana patients with Quintana infections are more likely to have lytic bone lesions than those affected with henselae. And in terms of the lesions, so cutaneous bacillary angiomatosis usually appears as this angiomatous vascular lesion that's quite difficult to diagnose because of the variations in appearance. Although in recent times we've been quite good at eyeing them in our advanced retro patients. But the lesions frequently consist of these papular or nodular lesions. Sometimes they become pedunculated or even verrucous in nature. But they typically first develop as these small, smooth, red to purple papules that can subsequently erode with or without crusting. They may gradually expand and form these large pedunculated lesions or nodules, and they can be quite friable sometimes, leading to bleeding when you try to manipulate them. So you can get a subcutaneous form of the lesions, and these are like deeper, tender nodules that can sometimes have an erythematous overlying skin. They may also erode through the cutaneous surface and then become super infected. And less frequently, the lesions can develop like a suppurative ulcer. You may have mucosal or oral involvement as well, and this can occur with or without cutaneous manifestations. But the mucosal lesions usually appear as these smooth purple papules or plaques, and they usually resemble things like KS, Kaposi sarcoma, or pyogenic granuloma. And then this is just an example of a patient that we had seen a while ago with cutaneous bacillary angiomatosis. Okay, so that last entity that I had was Bacillary Peliosis hepatis. So this is actually characterized by proliferation of the sinusoidal hepatic capillaries. And what that does is it results in these cystic blood-filled cavities that are just randomly distributed throughout the liver. So just like bacillary angiomatosis, it usually occurs in patients with advanced HIV, CD4 counts usually under 100, and patients with this syndrome can present with abdominal pain, hepatosplenomegaly, with or without any systemic features. But particularly in HIV, there's a few things that we need to think about, like HLH or hemophagocytic lymphohistiocytosis. So Bartonella henselae in particular has been associated with HLH, and this is based on numerous case reports. And then another thing to be worried about is iris or immune reconstitution. So it has been described before that people with HIV and Bartonella infection can develop significant worsening of the Bartonella infection after initiating ART. And this brings to question the exact timing for when to actually initiate ART. And the answer here is just really it depends on the clinical presentation of the Bartonella. And there has been some recommendations in persons with HIV with CNS or ophthalmic bartonellosis to actually defer ART by about 2 to 4 weeks after starting antimicrobial treatment for Bartonella. And the clearest guideline is from the NIH for this. But patients with other manifestations like skin manifestations or endocarditis, the recommendation is still to initiate ART as soon as possible, since restoration of the immune system may actually augment your response to antimicrobial therapy. So, in terms of diagnosing Bartonella, it can be quite challenging. And like I said earlier, it's because of the limited accuracy of the microbiological testing and the immense difficulty in culturing this organism. With the exception of cat scratch disease, the microbiological diagnosis usually requires serology testing combined with one or more definitive non-serological tests. And the non-serological tests will be things like culture or PCR or histopathology. But for cat scratch disease, the typical diagnosis is based on a characteristic clinical presentation, obviously coupled with the history of cat or flea exposure. And serological testing in these patients are mainly to just support your diagnosis of cat scratch disease. Um, but your standard blood culture bottles for Bartonella generally has quite a low yield, and there has been some evidence of collecting blood samples in an EDTA tube and then transporting them to the laboratory to undergo lysis centrifugation and then to be plated on an agar plate, and that seems to have increased the yield of being able to culture Bartonella in the laboratory. In terms of serological testing, it's not a definitive test for Bartonella infection, but it is often used as the initial test to either raise or lower your likelihood of infection. But a positive serology coupled with a strong clinical suspicion is often good enough to make a presumptive diagnosis. But like I said, should be combined with a non-serological test to confirm the diagnosis. There are many causes for a false positive Bartonella serology, and a few of them would include cross-reactivity with other pathogens. So there's common cross-reactivity with Coxiella species, chlamydia, and particularly also in patients who have received IV immunoglobulins. But like I said, the definitive diagnosis of Bartonella generally requires a positive culture or PCR test or a biopsy with histopathology on Warthin starry stain, which I'll show you now. And those are findings that would be consistent with a Bartonella infection. In terms of PCR itself, so most of the targets are the bacterial 16S ribosomal RNA. Um, but there is some newer techniques using microbial cell-free DNA by next generation sequencing, and that seems to be an emerging diagnostic tool. So this is an image of a positive Warthin starry stain. It's suggestive of active infection, but not definitive because Warthin stain can actually be positive for many other pathogens, and this would include other spirochetes, Treponema pallidum, for example, Borrelia, Helicobacter, Leptospira, etc. But essentially, what we're looking at here is the small, let me just get a point, the small black clusters that represent the Bartonella organisms that have taken up the Warthin stain, and this is by this solid arrow, and then the broken arrow here just represents the nuclei that have taken up the stain. Okay, so we'll move on to talk a little bit now about Bartonella henselae. So Bartonella henselae, the first convincing evidence of an infectious cause of cat scratch disease actually came in the early 80s in about 1983, again with investigators at the Armed Forces Institute of Pathology. And this was using Warthin stain, like I showed you just now, to demonstrate these organisms in lymph nodes of patients with cat scratch disease. In humans and cats, there are two main Hensley genotypic groups that have been identified, and this is based on molecular analyses, and that's the Houston 1 serotype and the Maasai serotype. In persons with HIV and less commonly other forms of immunosuppression, Hensley can cause bacillary angiomatosis and Peliosis hepatis, just like Bartonella quintana. Cats serve as the natural reservoir for Hensley, and the organism causes an intra-erythrocytic bacteremia that can persist for a year or sometimes even longer in some cats. But following inoculation of the Hensley into humans, the organism will typically cause a local infection that will manifest with regional lymphadenopathy. And then it will eventually invade into the endothelial cells, cause an acute inflammatory reaction, and an associated activation of the pro-inflammatory cascade. So, why do some patients have localized disease while other patients have developed or developed disseminated disease? It's really unknown. There has been some, genetic suggestion, as there was a link between HLA-B27 and uveitis in patients with cat scratch disease, but it remains largely unknown as to why some people will manifest with only localized disease and others with disseminated disease. And immunocompromise states on its own doesn't seem to account for this in its entirety. Okay, so in terms of transmission, so cat scratch disease can result from a scratch or a bite from a cat that may have been infected with or that has been infected with Bartonella henselae, as well as exposure to the cat flea. And this is the picture, the image that you see, Tinocephalides felis, which is the common cat flea for our tropical medicine people. You would identify this by this nice comb on the head and the absence of a mesopleural rod to differentiate it from other fleas. But this is the culprit flea. Transmission to humans can also occur through contact of cat saliva with broken skin or with mucosal surfaces. In terms of clinical manifestations, cat scratch disease presents in about 85 to 90% of children as this localized cutaneous lymph node disorder, usually quite near the site of inoculation. But like I said, some individuals may present with disseminated disease that may affect the liver, the spleen, the eye, the central nervous system. But in patients with localized disease, it's usually self-limiting, and people with disseminated disease can actually have some life-threatening complications. The primary inoculation lesion will typically persist for about 1 to 3 weeks. But the regional lymphadenopathy is actually the hallmark of this disorder. So cat scratch disease, the regional lymphadenopathy is quite classic. They will usually appear proximal to the inoculation site, and they will usually appear about 2 weeks after inoculation. The nodes are almost always tender, and they have an overlying erythematous skin, and they may occasionally suppurate as well. Hensley infection should be considered in the initial evaluation for any fever or pyrexia of unknown origin or any prolonged fever, particularly in children. So you can get ocular manifestations of the disease, and these may include a specific entity called Perinaud's glandular syndrome. And this is characterized by, again, tender regional lymphadenopathy, usually of the pre-auricular or submandibular or even the cervical group of lymph nodes, with infection of the conjunctiva or the eyelid or the adjacent skin. Yeah, and patients may also present with other syndromes like neuroretinitis, where patients will present with acute visual loss, and this is from optic nerve edema that is associated with macular exudates. They may also present with papillitis, optic neuritis, and focal retinochoroiditis. So in terms of neurological manifestations, there's quite a few, but commonly patients can present with encephalopathy, a transverse myelitis syndrome, radiculitis, cerebellar ataxia, etc. And in terms of musculoskeletal, myalgia, arthralgia seems to be the most common. There are quite a wide range of atypical manifestations like deep space neck infections and pulmonary nodules, etc. Okay, so this is a few images of what I've just discussed. You can see on the left is this typical papular lesion on the finger of a child with cat scratch disease. And then in the middle, this is left axillary lymphadenopathy. And on the right, you can see these exudates overlying the macula. And then you can see some actually radiating out from the foveal area. And this is actually referred to as a foveal star, or yeah, a macular star rather. And the appearance is quite characteristic of cat scratch disease ocular involvement. Okay, so approach to diagnosis here. So probable diagnosis is made based on clinical findings, like I mentioned earlier, and these clinical findings would be things like the tender regional lymphadenopathy, with or without a preceding primary inoculation papular lesion, and obviously a history of recent cat or flea contact. And then because of suboptimal sensitivity of diagnostic tests, it's recommended that empiric therapy should be initiated in any patient in whom is presumed to have cat scratch disease. Serology testing with EIAs or IFAs should be used to support your clinical impression, especially in patients presenting with atypical disease. But in essence, serology has the same shortcomings as that I just described with Bartonella quintana. A lymph node or tissue biopsy is not routinely required for most patients, but in some circumstances it may be warranted. And this may be in circumstances such as those patients who have delayed resolution of systemic symptoms, or in any patient in whom an alternative diagnosis like lymphoma or TB, for example, is suspected. A positive Bartonella henselae PCR in a tissue sample obviously confirms the diagnosis, and then a tissue stain with Warthin styrene stain provides again a strong support for the diagnosis, but isn't definitive again because Warthin stains many other spirochetal infections. And then the difficulty with cultures we've already discussed. Okay, so in terms of your treatment, so you have some experts that actually don't recommend treating cat scratch disease that manifests with uncomplicated lymphadenopathy. And the rationale for this, for not treating, is because most patients will actually have self-resolution of the illness without any subsequent complications. And the available data suggesting any benefit from antimicrobial therapy in these cases is quite limited. But then there are some that will argue that you should treat these patients in an effort to prevent serious complications from occurring, since it is said that about 14% of patients with disseminated disease, can present in a very, very complicated manner. But in terms of your antimicrobials of choice, you usually would give a 5-day course of azithromycin. In patients who are intolerant to azithromycin, then a 7 to 10 day course of clarithromycin or rifampin or even Bactrim would be recommended. And then for adults, ciprofloxacin may also be an alternative option. And then it's suggested that if patients who have lymphadenitis and don't respond to therapy after 3 to 4 weeks, you should obviously reevaluate for an alternative diagnosis. And if you can't, and you still think that cat scratch disease is the most likely diagnosis, the recommendation would be to repeat treatment with another 5-day course of this time combination therapy, azithromycin with rifampin for 5 days. In patients with disseminated disease, like those with hepatosplenic disease and or fever of unknown origin, you would treat with combination therapy of azithromycin and rifampin. And an alternative regimen here would be to use gentamicin, obviously given that the patient has normal renal function. In terms of neurologic and ocular disease, the optimal therapy for this is really unknown. Even the duration is just really a recommendation. But for adults and children older than 8 years, doxycycline is suggested in combination with rifampin. In children under the age of 8 and those unable to take, those adults unable to take doxycycline, rifampin with either azithromycin or Bactrim is recommended. So even with this recommendation, I'm not sure how the peds guys feel about it, but the American College of Pediatricians will say that even in children under 8, if it's life-saving therapy and you have to use doxycycline, a duration of under 21 days should be acceptable. I'm not sure if we are in our setting using doxycycline, not particularly for these infections, but just in general, for shorter or duration shorter than 21 days. Then for patients with neuroretinitis, the recommendation is to treat for extended periods for about 4 to 6 weeks. And then for patients with paranoid ocular glandular disease, the recommendation is to treat for about 10 to 14 days. Again, no hard and fast guide as to the duration of therapy. And you'll see now there's quite a discrepancy even with endocarditis. So this was the recommendation for endocarditis. So this is the American Heart Association, the AHA, that's been adapted together with the up-to-date recommendations. And then, it's quite busy, so just pay attention to the highlighted bits. But essentially, if patients can tolerate rifampin, you should use combination therapy with doxycycline for 12 weeks and then RIF for the first 6 weeks of treatment. But if they can't tolerate RIF and have any renal dysfunction, they should get doxycycline monotherapy, but you can see the duration is much longer for 24 weeks. If they don't have renal dysfunction, then you can give doxycycline for 12 weeks with a 2-week lead-in therapy of gentamicin, as you can see here. And then if you can't, in patients who can't tolerate doxycycline, the same algorithm would apply, but you just replace the doxycycline with azithromycin. So you can see the duration of therapy here is much longer. And this is really just based on consensus statement and not much robust evidence around duration, because you can see here the 2023 ESC guidelines would recommend doxycycline with gentamicin combination therapy for 4 weeks of doxycycline and a 2-week lead-in of gentamicin for Bartonella endocarditis. Okay, so then moving on to the last piece of the pie, which is South American Bartonellosis or Carrion's disease. So this is an infection caused by Bartonella bacilliformis, which is also a pleomorphic gram-negative bacterium. This organism is transmitted to humans predominantly by the bite of a female phlebotomine sandfly, which I'll show you a picture of just now. But the disease typically manifests as a biphasic illness with an initial febrile phase, which is known as Oroya fever, and that's followed by a secondary phase characterized by the development of these nodular skin lesions, which are known as verruga peruana. There have been variable clinical presentations described, ranging from asymptomatic bacteremia to fulminant disease. And infection occurred most frequently among children under the age of 5. And there seems to be a linear decrease in the incidence with increasing age, although the cause for this I could not find. In terms of the historical significance, so I'm sure everyone recalls the story from medical school, but there was a Peruvian medical student called Daniel Euclides Carrion, and he actually demonstrated that verruga peruana and Oroya fever are actually caused by the same organism. And how he did this, it resulted from what was described as a heroic experiment in which he actually injected himself with infectious skin lesion material from a patient known with verruga peruana. And he very soon thereafter developed quite a fatal infection of fever, hemolytic anemia. And as a tribute to this so-called heroism, both manifestations of the disease were actually named after him as Carrion's disease or Carrion's disease. So this is the culprit vector here. This is the Lithomia sandfly, and you can appreciate its pretty feathery wings that are held in this V-like position. They're quite small. They can't fly very far. They fly for about 100 meters or less, and they have quite a painless bite, mostly attributed to its very tiny size. So in terms of the clinical manifestations of bacilliformis infections, it can cause an acute febrile illness, like I said, known as Oroya fever. And the acute or hematic phase generally begins with an insidious onset of this mild fever-like syndrome with headache, anorexia, malaise, and then anemia subsequently develops due to the parasitic infections of the red blood cells and the cells of the reticular endothelial system, which subsequently get cleared from circulation. The acute phase will last about 2 to 4 weeks, and then the majority of patients who receive treatment will recover and will really progress to the eruptive phase of the disease, which should occur after a few weeks to months. In the absence of antimicrobial therapy, mortality is said to reach as high as 90%. But when treatment is started early, mortality is said to fall to around 10%. There are some factors that have been associated with poorer prognosis, and this is particularly in patients who have presented with petechiae, anasarca, or any altered mental status. Some other risk factors like age more than 45, again, history of alcohol use comes here, presentation with shock, pulmonary edema, pericarditis, seizures, coma, etc., has also been associated with increased mortality. In terms of the secondary phase with cutaneous manifestations, we get what's called verruga peruana. So the eruptive or verruga phase occurs after the organisms invade the capillary endothelial cells and induce the cellular proliferation, producing these hemangioma-like nodules in the skin and mucous membranes. This can appear about 2 to 8 weeks after the patient has completely recovered from Oroya fever. There may be other clinical presentations like verruga peruana without Oroya fever or recurrent verrucous illnesses, and these have also been described in the literature. The incubation period for South American Bartonellosis is said to be about 1 to 30 weeks, very, very wide, with a mean of about 8 weeks. And it's said that there's an interplay between host factors and genomic polymorphisms that explain this wide spectrum of clinical presentation. So, like I said earlier, there are three major types of skin lesions, and they're called miliary lesions, nodular lesions, or mular lesions. The miliary lesions, you see the top left corner, they are usually about 3 millimeters round, soft reddish pinpoint papules that are usually clustered in crops and are confined to the papillary dermis. If they are untreated, these lesions can progress to the nodular phase, which you'll see on the top right-hand corner. So the nodular lesions are these non-tender wart-like lesions that can become pedunculated. And then mular lesions you see in the middle are nodular lesions that evolve into these more than 5 millimeter lesions. Usually they're quite vascular, bulbous, and they tend to bleed easily and can also ulcerate. In terms of diagnosing Oroya fever is actually made by blood culture and or by identification of the bacilliformis organisms on a Giemsa stained blood smear. There may actually be a delay of about 14 days for the organism to grow on culture, and this is because it's fastidious. It requires a special Columbia agar, which is an enriched blood agar for growth, and it also grows at about 25 to 28 degrees, which is different from other Bartonella species, which readily grows at human body temperature at about 37 degrees. And then routine blood cultures, like I said, are useful for the diagnosis of bacilliformis infections. Verruga peruana, on the other hand, is generally based on a characteristic clinical features and with skin biopsy findings. Serology for bacilliformis infections, they have been developed and there has been an immunoblot test. And there has been some emerging results with PCR techniques for diagnosing bacilliformis on blood samples in patients with clinically diagnosed Oroya fever. Okay, and then this is a GIMSA slide showing the organisms intracellularly. Okay, then in terms of treatment, so prompt initiation of appropriate antimicrobial therapy is essential for patients with known or suspected infection. The optimal approach to treatment of either disease presentation is again quite limited. It's just based on some small case series and anecdotal evidence rather than robust clinical evidence. But in vitro susceptibility testing of Bartonella species is quite hard, and that again is because the organism is quite fastidious, difficult to isolate in the laboratory, and this prolonged incubation time. Um, Verruga peruana, it suggested that azithromycin be used in adults and children and pregnant patients. And azithromycin has been shown to have clinical efficacy that's comparable to that of rifampin, which is also used to treat verruga. For the treatment of uncomplicated Oroya fever, in non-pregnant adults, the recommendation here is ciprofloxacin. And again, I'm just highlighting that data for any of these approaches are quite limited, and it's really based on observational data and clinical experience in endemic areas. For the treatment of uncomplicated Oroya fever in children and pregnant patients, the recommendation is Augmentin or Comoxiclav. And then for severe disease, the recommendation is ceftriaxone with adjunctive dexamethasone that recommended in certain individuals. Again, no clear-cut guideline as to what to use when and for how long. And I think with that, I've come to the end.
Cool. Thanks. Thanks. Your cat there looks much more vicious than than you think. Okay. So yeah, great. And we're happy to take any questions. So if you have any, just type in the chat. I guess Tara, one of the surprising things coming out of the Stellenbosch data was how much endocarditis is caused by Bartonella.
Mhm.
And I mean, it was, staph is number one by, quite some way, but I mean, this was the second most common cause of endocarditis in their pretty well worked up cohort.
Mhm.
Um, what would you advise clinicians in South Africa in terms of working up causes of endocarditis? Like, when would you worry about Bartonella, or what would you suggest?
Look, so it has changed a lot of what we do when working up culture negative endocarditis. I mean, we should always be probing for an appropriate history, but now we probe even harder for any of the risk factors that might be associated, like homelessness, chronic alcohol use, etc. And then in those patients, obviously, we'd suggest serology. And then very interestingly, anecdotally, Jeremy, we so our at Charlotte our valve replacement, so the valve that is debrided or removed in theater is reflexly sent to the lab for PCR. Sometimes it's missed and sometimes we have to go and request it ourselves, but it's done. and we've seen quite a high proportion of Bartonella in our culture negative endocarditis patients as well. This is just from our experience. And I've actually myself seen it across all our sites on the VIT circuit of hospitals. So we are seeing it more now that we are looking for it. So I think, yes, a prudent history, you need to probe deeply. And if there are risk factors, you should be doing serology. And then some sites would advise to add doxycycline to your triple empiric antimicrobial therapy on day 5 after you've deemed the patient a culture negative endocarditis case.
Yeah, so I mean, I think those are the two interesting sort of time points. I mean, one is, do you investigate from the start, or do you wait to see if you get culture negative? And I think, given that it's quite a long time, it's brewing, it's not an acute, it's a sort of subacute process. You probably could wait at least, as you say, 3 to 5 days to see if something else cultures, because most of them are staph still. And then you save that. And then, and then the similar question about therapy, would you start it up front, or would you wait to, if it's culture negative, or would you only give it if it's antibody positive, if, depending. And I think those are open questions, right? And
Mhm.
our policies, at hospitals, like you said, is more or less the middle option of probably adding doxycycline routinely to the truly culture negative ones. But the sadness, of course, is that many of the culture negative ones are not truly culture negative. It just means they, someone started antibiotics long before they thought of endocarditis, and so didn't take the cultures right. So it becomes quite murky.
Mhm.
And yeah, we have some sort of thoughts on it and some things we're doing for it, but it's a difficult thing. And but congratulations again to the really excellent study from Stellenbosch, which really opened the door to this widely and showed how prevalent it is. And I think it's a big thing.
Mhm.
Um, and then, you mentioned in terms of the therapy for the endocarditis, you said, the Americans went with rifampicin as a second agent with doxy, and the
Mhm.
Europeans still with Genta. Is that based on anything other than just side effects, or, is there any efficacy data that the Americans suggested would replace Genta, for why they went with rifampicin rather than gentamicin, which was the sort of historical choice?
Yeah, I couldn't find I couldn't really find anything as to why that recommendation was placed instead of the gentamicin. But we know that there's a move away from gentamicin in totality for endocarditis. I mean, particularly for the enterococcal endocarditis cases, because we have seen, of course, synergism with AMPI, ceftriaxone is better. So I'm assuming it's just really purely based on the nephrotoxicity that we're trying to avoid.
Yeah, it's interesting. Yeah, I mean, the other endocarditis, I guess, when we have straightforward rationales, like you said, it doesn't help with staph, and for enterococcus, you have an alternative, which is at least as good, in Keftrax. And this, I wonder, I mean, the original studies were not great. They were done in France by our much lamented Diderot at the moment. He led many of the trials, um, and yes, I mean, I think the level of evidence is very poor, and it may just, as you say, reflect, accessibility and tolerability rather than anything else.
Mhm.
Yeah, I think given the amount of stuff there is here, though, South Africa should hopefully take the lead in some of the stuff soon. Should be interesting to see. Cool. And then I see there's a few thank yous in the in the chat. Um, then Professor Moose is saying, does the organism Bartonella infect normal valves due to the prolonged bacteremia, as opposed to, I guess,
Um,
different valves?
yeah, so that's the idea that it's not really based on your risk for endocarditis, so to speak, but just the bacteremia itself is a high risk.
That's my understanding too. Yeah. And then Professor Blumberg's mentioning doxycycline is not the same for tetracycline as in children about the adverse drug reactions. And I think that's come up before. I don't know if you want to elaborate on that, Tara.
I'd rather please take on that, Jeremy.
Well, let's see. The pediatricians on the call, raise your hand and I'll unmute you. But I mean, I think the concept is really specifically about stuff like the tooth staining and aspects like that, where the old tetracycline had a low but important risk, and the risk with doxycycline is meant to be much shorter, much lower rather.
Mhm.
In some settings non-existent, and it's depending on the sample. I think we'll let pediatricians talk for themselves if they want to. Um, cool. All right. I think that's it. I'm just going through the comments again, but I think that's it. Riet, I've got a hello from you. I will say hello to you too, but I don't know if you want anything else. Oh, okay. Then a couple of other questions have just come through now, Tyrell. Riet saying, do you have a specific request for the lab to test blood cultures? In other words, if you try
So
to grow them.
no. So we don't actually do the EDTA sample collection. So you would just so if you are suspecting, a case of endocarditis, you should always tell your microbiologist and infectious disease specialist, as well as obviously your cardiologist. But they should be aware of what they're dealing with in terms of what to look out for in the lab. But there isn't anything specific in terms of culture for our labs, no.
Cool. And then Lauren has asked, one of our different Laurens has asked about empiric infective endocarditis cover. So, I mean, I think that's what we were talking about a bit earlier, Lauren. I think that we don't know what the best strategy is. Certainly in Joburg, a lot of us have started adding it empirically once we have a culture negative endocarditis. In other words, if you haven't grown anything in, say, 5 days of standard cultures, and then to add it at that point. But I think the optimum strategy is not known, and I think it's reasonable to go one of several ways. But that's been our approach. So we don't start it up front directly because most of them are still staffed by a long way. But if nothing grows, then we usually add it in empirically and then do serology to see at least if we, if it comes back negative, we sometimes stop at that point. But in that, the serology takes a while for us. It usually takes a week or so. So in that interim period, we at least add the doxycycline, and then obviously if it comes back positive, we'd add a second agent too. Cool. All right, but like I said, there's one of many approaches, not necessarily the right one. We're all a bit scratching our heads to find the best strategy.
Mm.
Great. Okay, thank you, Tyrell. That's really nice. Lots of nice comments in the chat, and yeah, well done. Nice.